Now, when you have a patient with suspected acute myocardial infarction in the emergency department, what is your stepwise approach? Doctors, today we want to make sure that we've beaten chest pain flat, and chest pain does not have any dominion over us, okay? So now, chest pain, if the patient has chest pain and the pattern is suggestive of acute coronary syndrome, what are your steps? In the first 10 minutes, you want to triage the patient and get the patient to, a rapid care area. That is where you manage all your cardiac patients. Number 2, remember that I told you quickly, you want to get your ECG. Number 3, while you're doing that, you want to obtain a quick history and then do a quick physical exam. Most of the time in acute coronary syndrome, you'll not really be able to pick a lot on physical exam, especially the patient is conscious, okay? Next, you want to give your aspirin. Next, you want to give your nitroglycerin unless it is contraindicated. So this is what I was talking about. Now, within the same first 10 minutes, you want to establish your IV access. And then while you're establishing your IV access, you want to draw blood for your initial blood work and your biomarkers. And you also want to make sure that the patient is on continuous cardiac monitoring. And if the patient is needing supplemental oxygen, you want to make sure the patient is getting it. Now, this is the next step. And I hope that you can be able to memorize this and provide it if you need to provide it. If the initial ECG is not diagnostic of an acute coronary syndrome, say anterior MI or something, what you want to do is to repeat that ECG. You're telling yourself, I think this patient actually has myocardial infarction, but then I'm not seeing anything on ECG. The fact that the ECG is normal on the initial one does not mean that the patient does not have acute myocardial infarction. So even if the ECG is normal, you want to repeat your ECG in about 15 to 30 minutes. If your initial ECG is not giving you the right vibes, okay? Now, if you repeat your ECG and the patient meets the criteria for, MI like ST segment elevation in the specific leads, then you want to go ahead and do your anticoagulation with low molecular weight heparin. You want to give beta blocker if it is not contraindicated and the patient is not bradycardic, okay? And you can then give even your nitroglycerin. Then you want to hop on the phone right away and talk to the cardiologist who is in the PCI center that, hey, I have this patient. The patient just suffered an acute coronary syndrome. This patient needs to be in your center right away. And we need to do the PCI within 90 minutes. That's why when it comes to chest pain, time is very essential because you don't want to delay unduly. As soon as you start delaying unduly, trouble. Okay. And then if the possibility of getting the PCI right away is low because of distance, then you may want to do your thrombolysis. So that is somebody who you are cocksure that this patient has acute myocardial infarction. You've done your ECG, everything shows. Now, if you have a strong suspicion for acute myocardial infarction, but the ECG is not showing any ST segment elevation, but in your heart of hearts, you feel like, this patient may have an acute myocardial infarction, then what you want to do is to go ahead with your anticoagulation study. So far as the patient does not have any contraindications, you give your beta blocker, you give your nitroglycerin, which will help with blood pressure control, which will also help with the pain. Okay. And then we said that we will repeat the ECG. So you'll further look, the new ECG, is it showing any ST depression? Because it can be non-STEMI and non-ST segment myocardial infarction. And then you also want to, maybe around that time, is the lab calling you with the results of the blood work? Is the patient having persistent chest pain? Is the patient becoming hemodynamically unstable? Is the patient having an increased risk score for myocardial infarction? Okay. Then with that, you want to do your characterization if the patient has high risk features, and you then can do medical management if the patient is a low risk patient. Now, if your initial ECG did not show any ST segment elevation, your repeat ECG is still normal. You don't just let the patient go home. you want to keep the patient in the emergency room and keep your tabs on the patient. Okay. And while you're keeping your tabs on the patient, you want to repeat the ECG in 6 to 12 hours. Usually in Canada, we want to repeat it in 6 to 8 hours. And if there is then evidence of infarction, then you want to treat it as a non-STEMI. But if there is no evidence of infarction, even after the 6 to 8 hour repeat ECG, then what you want to do is to perform a stress test, or you want to do some imaging, maybe refer the patient to see a cardiologist for an echocardiogram. So please know all these various possible scenarios you can meet in real life and as you prepare for your exam. If it is obvious, call the cardiologist, give your low molecular weight heparin, give your aspirin, give your beta blocker, give your nitroglycerin, ship the patient off. If you're not very sure, you think this patient should have an acute myocardial infarction, first ECG does not show anything, don't throw your hands into the air. Repeat the ECG within 15 minutes. While you're trying to repeat it, you're managing the chest pain with all the medications you can use, including your nitrates, and if the patient does not have any contraindications, and then you want to get a cardiologist involved. But if your first ECG was normal, your next ECG is also normal, that is within the 15 to 30 minutes, then you want to keep the patient in the emergency room and repeat the ECG in 6 hours. Doctors, is that okay? Is that clear?